Good afternoon. Welcome once again to our webinar series entitled Frontline Report, Autoimmune Liver Disease and the Pandemic. This series of webinars are made available via collaboration between the Autoimmune Hepatitis Association and the Center for Autoimmune Liver Disease and Cincinnati Children's Hospital. I'm Craig Lambert, the Executive Director for the Autoimmune Hepatitis Association and also an adult hepatologist at Indiana University. I am once again excited to help host this fourth webinar in our series entitled The Patient Perspective. Quickly, a disclosure from the AIHA. This webinar series does not replace your primary physician, gastroenterologist, or hepatologist. We cannot diagnose, treat, or manage symptoms associated with AIH. As you may remember, last week we were able to see the coronavirus pandemic through the eyes of two hepatologists working closely with COVID-19 patients in New York. This week, as the title implies, we will get first-hand experience of what it is like to be an AIH patient with COVID-19 and be hospitalized because of the symptoms. Before we spend time with our special guest, I want to reintroduce Dr. Aaron Ermel, an infectious disease doctor at Indiana University. He is with us once again to help us digest the recent information pertaining to the coronavirus and the AIHA community. We will be discussing questions, many submitted by our members. Dr. Ermel, thank you again for joining our webinar and making yourself available for our community of autoimmune liver disease patients.
No problem. Thanks for having me.
Any general updates on virus activity across the U.S. You are seeing in the news or here locally too?
Yeah, so if you look nationally, our trend is it's a bit of a plateau, but I think we're starting to see what had been in general predicted, which is our rural communities are starting to see the increase. Our larger epicenters that were in the news about a month ago are finally starting to see things calm down. But what we're starting to see are those rural outbreaks. You're seeing more of our vulnerable populations being identified. So we knew nursing homes were a problem, but this is still ongoing. And then as you've heard, I mean, in Indiana, if you actually look at our hotspots at a county level, they all seem to surround meat plants, packaging, and processing plants. When you see these large numbers, it's actually just like very specific groups who are being tested positive. So I think that's kind of interesting in the sense that we're not seeing just everyone affected the same way. So now we've gotten to our micro outbreaks. So.
Right. And so now thinking about this as we move into the opening or at least partial opening of our communities, depending on where you are across the country, what kind of things keep you up at night, or what does an infectious disease doctor worry about the most?
Yeah, I mean, I still worry about community spread in areas as we start to reopen. That does make us a little nervous. Is it too soon? I can't tell you that, simply because, our surveillance infrastructure, which makes me actually the most nervous, was only recently in place. So what we were doing before, whereas testing, and there was very big focus on testing of hospitalized patients, is not a surveillance system. Right, so those are only patients who seek help that you're going out there. So right now, we've only been conducting kind of our community-based surveillance to really see what's out in the community for a short time, and not having a better grasp of what that prevalence looks like is what makes me a little nervous as we begin to reopen, right? So, and the virus hasn't been around long enough to see the kind of virulence or how sick it makes people decrease over time. So it could still be just as severe in the right people. So I think that's what bothers me the most is that we're still trying to grasp how we deal with it in the community.
Sure, and that makes a lot of sense. But you also talk a lot about federal and local agency work and what infrastructure you have. But what about patients and the public? What can we do better to help this?
Right. So, even though I am sometimes plus minus on mask usage, I do think that the use of masks and kind of reducing just kind of your time in high population density situations, like where you're going out and being in any sort of crowded event and things, is probably what we're going to have to do for a little bit longer period of time. I don't know the best answer as far as how we reopen restaurants and things in a way that's both economically viable and safe. But I think if people, especially if they're feeling ill, they either need to stay home or wear a mask. I think that's what's going to be the best thing that we can do. in the for the rest of the public. So.
Sure. And I'll kind of talk about mask use. I was out personally this past week for once, and where I was the only one wearing a mask. You know, the guidelines for mask use across the U.S. and even locally, is this going to change? Should we be ramping this up? And would the U.S. moving to more of a mask culture be helpful?
Yeah, I mean, it's, the data surrounding masks is always a little nebulous, like how effective this would be. I think, it's interesting you mentioned your experience, because I thought that like a week ago. I was actually with my wife in Whole Foods yesterday, and fortunately I did wear a mask, because I would have been like the only person without one. So talk about that shaming, that social contract. But I think what maybe not wearing a mask all the time, if you look at long-term cultural ramifications, but really kind of imitating what we see in Asia, which is, I feel like I have a cough, I don't feel well, I'm going to wear this mask. So it's really preventing spread from you to others that maybe we should adopt. I think the big question, though, is that if people are going to promote masks, I think we need to make sure the supply of masks is sufficient to do so. I mean, I think that's the big problem. Is you can say that all you want, but if we don't have them, and we're not really sure how well cloth masks actually work, then we really need to make sure that the appropriate masks are available for the public.
Sure, absolutely. So in transition, speaking about going back out into the community, there was a recent article in a journal entitled Emerging Infectious Diseases, which I wanted to highlight and maybe get your input, but just a brief summary for our members. This paper is entitled COVID-19, Outbreak Associated with Air Conditioning in Restaurant, Guangzhou, China, 2020. The authors of this article report on 10 people with COVID-19 from 3 families who had eaten at the same air-conditioned restaurant in Guangzhou, China in late January. Here's a floor plan of that restaurant that was included in the article. This restaurant is an air-conditioned 5-floor building without windows. This 3rd floor dining area you're looking at here, each floor has its own air conditioner. The distance in between each table is about 1 meter, and the air outlet and the return of air inlet for the central air conditioner were located above table C, and it's right here on the right side of the screen. Important to know, family A, sitting at table A, had traveled from Wuhan, China, and arrived in Guangzhou on January 23rd. The following day, the index case patient, or the patient the authors found to develop the disease first, patient A1, highlighted in yellow, ate lunch with 3 other family members sitting at this table at this restaurant. 2 other families, B and C, sat at neighboring tables. Later that day, patient A1 experienced onset of fever and cough and went to the hospital. By February 5th, approximately 2 weeks later, a total of 9 others had become ill with COVID-19. 4 members from family A, 3 members from family B, and 2 members from family C. The investigators found the only known source of exposure for the affected persons in families B and C was patient A1 at the restaurant. Dr. Ermel, are there any lessons here for the public or for our group of patients that we can employ to keep us safer?
Yeah, I mean, I think if you just look at the outline of the tables there, so the distance between them, it's not what's actually being recommended right now or what's trying to be attempted in all of the restaurants, at least as we're trying to reopen. That's the point of the 50% reduction in capacity for restaurants. I don't know about the air conditioning systems. That the unit that was on there, it looks like it was one of the wall units that has the same kind of outflow and then also recycling of air, very proximal to the air conditioning. So I don't know how we could modify all of those systems, and was it really contributory to it, because it was still, if you notice, those tables, those 3 were in proximity to, much closer proximity to I guess the incident, the case there. And if you notice too, the people, that not everyone at each table was affected, so the attack rate I would have expected to be a little bit higher than that. But it just goes to show that some of that distancing may play a role into preventing spread later on.
Sure. No, I think that's great insight. We've also heard now of reports of positive cases that then become negative and then in follow-up become positive again. I think we've even discussed this on prior webinars, some of the data that's come from South Korea. Do we have any more information on this now as we've studied this phenomenon?
Yeah, I tried to pull a few more papers looking at repeated sampling in individuals. And so what I actually found was that if the sampling technique was maintained, we were actually seeing pretty consistent positivity. So with those individuals who were positive, negative, positive, again, I kind of wonder if that was really more reliant upon testing and the technique, because even asymptomatic individuals who have had who were tested positive initially, the viral load, so the amount of virus that we can detect, which we standardize over time, that actually was consistently, there was consistent reduction within a 14-day period, and they were persistently positive. It's just less and less. And locally, even our data where we're following people on drug trials, we're sampling probably every 2 to 3 days, and we're noticing persistent positivity from these people. Now, most of them have been severe, so I can't look at the asymptomatic. But I wonder if some of this was just more reliant upon sampling technique. Yeah, because as people are doing this more, we seem to find consistent detection.
Right, right. Well, that's at least reassuring. And speaking about the virus, you know, everybody talks about SARS-CoV-2 or coronavirus as if it's one. We know this is probably not necessarily true. And in the media reports this past week or so, one group had published findings that there are a number of circulating mutants of this virus. What does this mean for us, for patients, and what are possible outcomes of this?
Right. So the mutations in RNA viruses would not be uncommon. We see this even within HIV and like hepatitis C, which would be other correlates, where within one person you can see multiple isolates at times, just because their high rate of reproduction. In SARS-CoV-2, and as I was trying to look into what some of the mutants have been, for me, when I think of the mutations, I look at what number of mutations, but then also where they are and how that would affect both virulence and then therapeutics. So I found it interesting. There's actually a couple of papers recently. Unfortunately, all these are pre-proof, and so I take them with a grain of salt. But when they've looked at mutations, they were even finding mutations within China already within their epidemic, so it wasn't even an international spread. But they actually found that in certain areas, the mutations made the virus, if you would, like weaker, in the sense less transmissible, because it affected that spike protein that we're all focused on as far as antibodies and potential vaccines. And so that it really wasn't as effective as it was before, at least theoretically. So for me, it's really more important to like look at, well, what was it that mutated and how divergent is it? And then does it actually affect what we're trying to do for the virus and its other characteristics? Because mutations don't always mean that the virus is worse than it was before. And in fact, they could be almost dead ends for the virus.
Sure, and that makes sense. I think the concern, and particularly the tagline with some of these media reports, was more infectious. Is that a possibility as well?
That could be a possibility. It would not be following the trend that we see in pathogens over time, is that depending on the selection pressures, we do see some times that like any virus and a lot of pathogens over time will become less infectious simply because they lose their host. They tend to burn out a little bit. This is kind of why in Ebola we always look at it as a little bit easier to contain because it's so identifiable, right? So,
sure.
So with coronavirus, you know, it just depends. You would think it would, for survivability, maybe not become as infectious, but I think the thing I worry about are the therapeutic ramifications. And if it were infectious and it were to mutate and adapt to the therapeutics that we have, then that's the selection pressure. That's us changing it. That bothers me the most.
Sure, and that makes sense too. So there was another big press story that came out this past week or so, and this was a treatment drug, finally, Remdesivir, beyond plaquenil or hydroxychloroquine. Remdesivir had some great press, and generally speaking, we thought maybe you could help us understand what were the benefits that were observed in patients with COVID-19.
Yeah, I think the big win for it was that toxicity seemed to be pretty minor, that we didn't see a lot of events that we could attribute to the drug. So that would be different from some of our other things that we were trying earlier on, with like hydroxychloroquine, this azithromycin, being the big problems with like causing like heart rhythm issues. The thing about remdesivir so far that we know is that it seemed to increase or decrease the time to recovery, so that then patients who receive the drug seem to recover faster. I have not seen any of the data yet regarding what it did to the virus. But it did seem that since we had placebo-based trial versus just our compassionate use, was that the time to recovery was shortened in the patients who received the drug versus those who did not.
Sure. And so speaking of patients who received it, many of our patients may not understand who gets to take remdesivir, who gets this prescribed specifically, what do they look like?
Yeah, so the way the trials are being managed, at least locally here, and these are the multi-center trials that people are seeing in the news, is that right now they have two groups. So they go for the group that has the most severe disease, are usually intubated, have some other organ failure, though there's certain organ failure that keeps them off the study. And then we have patients who are in our moderate, who are not requiring, that ventilator. They're receiving just supplemental oxygen. And so that's how we're determining it. So we have our selection criteria that for the study. So we review that, we approach someone, and then the family has to consent, or the patient has to consent to even receiving the drug. And then they're randomized into whether they receive the drug or not. And that's really the only way that most places can get a hold of it, is enrollment on the trial. They've kind of reduced their compassionate use arms, which is, hey, we have nothing else, can we give this? They kind of want everyone to be on the trial so they can get the most data.
That makes sense. And maybe just to hear from you, those with mild symptoms, it seems like we're still just offering supportive care out in the community at home while quarantined, correct?
Yeah, that is correct. So we really haven't, as far as I know, started any mild symptom treatment. And that's, it's kind of like what we do. People, this isn't the first idea, when we actually treat flu, if you have no other underlying conditions, so most of the patients with like autoimmune hepatitis, if they were on immunosuppressant, I give them Tamiflu regardless of how they were feeling. But in somebody who was not like that, if they were already getting better, I wouldn't give it to them. I'd say, well, you don't really need it. It's not going to do much at this point. I think it's kind of similar thinking when we look at remdesivir. There may be a trial down the road where they want to look at it in those people, but we're not doing that right now given the supply. So.
Right. Very good. And then maybe we could just briefly focus on antibody tests, and seen some press about antibody tests being now available through a number of different manufacturers and different lab testing locations. But we're also seeing some variability in these tests. Is this important to us as consumers and as doctors are starting to prescribe or order these tests more often?
Yeah, I mean, there is a lot of concern with the performance of these assays. So there are some that, frankly, it performs, terribly, and we're being marketed though ahead of some of the other little bit more well-studied tests. The the FDA link that you provided me, that I already looked through. A lot of the performance characteristics of those tests look very good, but those are ones that have kind of, I think, tried to look at how well their tests work. And as health systems and governments actually look to this, they're going to be looking at those data. One of them that's performing exceptionally well is not one that's made en masse, but was published as a protocol from Mount Sinai. And this is something we're trying to use as a research basis. And if you look at its performance characteristics, it's one of the better tests. But that's because it was kind of had some history to it and was rigorously studied. And so I think over the next couple of months, we're going to see a lot more data come out in the functioning of these tests. The early ones just seem to not perform very well. And what people don't understand is that, just because you get a positive test, these positive tests, I'd rather, a wrong answer is actually just as bad or worse than not having one. So that's why we're paying attention to these.
And so knowing that statement, what you just said, how, as an infectious disease doctor, how should primary care doctors or a hepatologist be approaching these tests? Should I be ordering these on my patients that want them?
It depends on the test that's being used, you know, and kind of consulting with either like your, the laboratory that would be running the test. So the patients want it and there was some sort of clinical indication. That's the other thing that we do in infectious disease that people don't realize is I do send a lot of tests. I mean, I will admit, we're probably one of the worst specialists for sending tests, but it is usually prompted by a clinical syndrome that might be compatible with what you're thinking. So if there was concern that, you know, there was COVID-19 and you're going through the symptoms, you say, oh, this could be one of the things, then you might want to send that test. But I guess you don't want to go down that road of COVID-19 when in reality you have something else that's fully treatable. So
Certainly.
I think that's, you know, and if you were getting these false positives and it sent you down the road of COVID-19 for which we would do nothing, but yet they had something else that we could treat, I think you wouldn't want to do that.
Right. And the reason I bring up that question too is because I'm getting in my clinic, you know, my patients that are very savvy, realizing that there is a lot of asymptomatic spread and asymptomatic infections. So in fact, they're hoping that this antibody test comes back positive to show that they've had this infection and they are now, quote unquote, done, which again is another question in itself. But again, would you recommend someone that has been asymptomatic throughout the course of the past few months get a test yet?
Not yet. I think there's a rather active ethical debate on the use of antibody testing, and I personally, and this is just my opinion, the use of terms of like immunity passports and things I find very disturbing, especially since we don't have great testing for it and we don't even know what those test results really mean. So using it as a way of determining eligibility of employment or I can go out and do whatever I want, I think is probably, it's premature to say that. But I think in the next few months we'll be able to develop a nice test. I think that's well within our reach. It just would wait a little longer till we have more data.
No, I think that's great information. And finally today, Dr. Ermel, I have a direct question from an AIHA member asking, have there been any updates to say whether people who are on immunosuppressants may be less likely or more likely to get severe disease? And before I get your thoughts, I'd like to comment that the impact of chronic immunosuppression on patients who get COVID-19 is just not known yet. And as in our prior webinars, we reviewed data that suggested that there's not much evidence of risk for severe outcomes related to only immunosuppression in prior coronavirus epidemics. However, data pertaining to the current pandemic is scarce, but remains highly relevant since the immune system's reaction to the coronavirus may be in fact what is associating with the lung injury that we're seeing clinically. I want to briefly share a recent paper looking at 90 solid organ transplant patients with COVID-19 in New York, as it does lend some data to this question because of these patient immunosuppression regimens that were included in this paper. This group of 90 patients had a median age of 57 years old and included 46 kidney recipients, 17 lung, 13 liver, 9 heart, and 5 dual organ transplants. Mild disease in the study was defined as patients receiving outpatient care only. Moderate disease was admission to the hospital or the general inpatient floor. Severe disease included patients requiring mechanical ventilation, admission to an ICU or intensive care unit, or unfortunately died. Using these definitions, 22 patients or 24% had mild disease, 41 patients or 46% had moderate disease, and 27 or 30% had severe disease. The moderate and severe cases were hospitalized, as you remember. Among the entire group, 16 patients died. This was 18% overall during the study duration. When compared to non-transplant patients hospitalized with COVID-19 in international patient groups, the hospitalized group of 68 patients in this study had higher rates of severe disease and death. However, testing limitations likely led to undercounting mild or asymptomatic cases from the community. Thus, I think we have to interpret these findings with caution. Furthermore, the transplant patients in the study had high prevalence of other comorbid conditions, such as older age and high blood pressure, that have been associated or with established risk factors for severe disease related to COVID-19. Dr. Ermel, any insight in this paper, general thoughts about immunosuppressed patients?
Yeah, I think there were a couple of things that I pulled from this, and one you already mentioned, the comorbidities, that there wasn't anything that stood out as particularly different from our non-immunosuppressed patients for which we have a lot more data. The second was the type of immunosuppression didn't seem to differ with based on disease status, so I think that was also reassuring. I mean, it would be interesting to be able to link it to one, but at least we don't have a sector of the immunosuppressed population that would be more at risk. The only thing, I think another limitation that maybe I missed it in the paper I'm reviewing, but was that, you know, what does this actually look like compared to the general population? So there are statistical methods that we could use from, especially in an epicenter like New York, where we could have taken the population and said, yeah, so we've sampled this group. What did it look like to our non-immunosuppressed population? Was that really significant if you looked at the outcomes? I think that was the big one, because telling me that maybe a third of them or whatever had severe disease doesn't tell me a whole lot if a third of everyone else had severe disease. So I think that was something that needed to be pointed out. Our own data, so we have a registry that we've developed for any patients diagnosed with COVID. We've just had so few transplant patients with it. I think that's fortunate to say that they're more likely to have severe disease. So we locally have not seen these trends, but we're not the epicenter that New York is. So I think this paper is helpful to show that most of the predictors we would use of severe disease in our non-immunosuppressed patients still seem to hold true in the transplant population. But that hope that maybe the downregulation of the immune system maybe isn't doing as much as earlier reports would suggest.
Right, and I think it's an important point that we just need a lot more information. Would you agree?
Yes.
Great.
I mean, I think this is something for like a multi-center type look, you know, maybe that the transplant network will be able to pull together.
Absolutely, wonderful. Well, Dr. Ermel, thank you for your time today. Again, we really appreciate your thoughtful responses and your guidance during this time. So thank you.
Thank you.
On behalf of the AIHA, I want to wish all of our members and their connected family that work in the nursing and caregiving fields a happy Nurses Week and say thank you. I think it is really important to recognize nurses and caregivers for the work they do. They do a lot more beyond just providing medical care. They are almost always central to the successes of their families, communities, organizations, and all of healthcare. On a personal note, I would like to expand this to say thank you to all of our essential workers and frontline care providers as well. I learned very early in my medical career that nurses and ancillary staff are often the most important people in the hospital. This importance was solidified for me even more in my life outside the clinic, when I married an emergency room nurse 13 years ago. I think this meme would resonate with many physicians and their practices. It's just that unfortunately true for me at home as well. And I think our special guest for today's webinar would also recognize the impact of nurses, as not only does she have AIH, she is also a nurse. But I will let Erin Anderson, our Director of Programming and Advancement, who will lead the patient perspective story, introduce her. Thanks, Erin.
Thanks, Dr. Lambert. We're grateful to have Aricia McCrae joining us today. Aricia is an AIH patient from Indiana who is a nurse. She recently recovered from COVID-19 and is here to share her experience with us. Welcome, Aricia, and thanks for being here.
Thanks for having me.
Before we dive into your experience with COVID-19, can you tell us a little bit about your journey with AIH? When and how were you diagnosed?
Yes, I was diagnosed in, I think, the end of July of 2017, diagnosed with AIH from a liver biopsy and blood work. When I went to the hospital, my labs were like through the roofs, and you know, my LFTs, they were like in the thousands, and you know, yeah, I went to my primary care doctor, and the next day I was at work and they called and they told me, go to the hospital now. So yeah, so my labs were like crazy through the roof. So my journey with AIH have been, you know, very difficult. Since diagnosis, I've just been in and out of the hospital. Main symptom, fatigue fatigue. I tell Dr. Lambert all the time, I know when I'm having a flare is when I can't when I'm just so exhausted after taking a shower. You know, I just can't take a shower. You know, that's like a pet peeve for me, and I always mention it, but yeah, it gets very difficult with the symptoms and everything.
What stage fibrosis did you have at diagnosis, and what medicine are you currently taking?
When I was first diagnosed, I didn't ask about a stage, so I don't know what my stage was then. I was just very shocked, and AIH I hadn't heard of at all, and even being a nurse, the diagnosis was just definitely a shock to me. Like, what is this thing? I don't know. But my stage now is a 3.
And what medicine do you currently take to help control your AIH?
Well, I'm taking right now. I'm taking prednisone and tacrolimus, but in the past I've taken azathioprine and budesonide. I've taken all of those, and I've had 2 infusions of rituximab also.
And how are you doing today with your AIH? I know you mentioned you've been in and out of the hospital, and it sounds like you've changed medicines quite a bit to try to find the right medication to work for you, but how are you doing now?
I take it day by day. Some days are good, you know, and sometimes I'm just bedridden. So, you know, I just kind of take it day by day.
You mentioned fatigue being one of the biggest challenges. What other symptoms or side effects from the medicine do you experience?
I have blurred vision from the prednisone, nausea from the AIH. I have muscle aches. I have when I'm having a flare, I have right upper quadrant pain there. Heartburn. I get heartburn really bad sometimes.
That was really challenging, and I know
Yes.
members deal with some of those same symptoms. Leading up to the COVID-19 outbreak, how were you feeling in general?
Well, I was doing okay. I was feeling okay. I had just gotten out of the hospital the beginning of March. The beginning of March, I had a flare and had just gotten out of the hospital, so I was recovering from there. Each time I have a flare, the recovery time gets longer. So, you know, I was recovering for that, and then just start feeling really bad.
Were you worried about contracting COVID-19, as all the news is full of stories about the coronavirus?
Yes, I was very worried because I am one that's in the category of immunocompromised. So yes, I was very worried, and I just, I thought I was staying in the house, thought I was being very cautious and everything, and I don't know, it just it just came out of nowhere for me.
Did you have any communication with your doctor about ways to protect yourself, especially because you're on immunosuppressants?
Yeah, we spoke about it a couple of times. His main advice was to stay in. Don't go anywhere, stay in. And make sure you of course wash your hands and don't touch your face, or all of that. Wipe your doorknobs down, the fail-safe stuff. Mm-hmm.
And now tell us a little bit about how you came to be diagnosed with COVID-19 and some of the symptoms you were experiencing.
It just came all at once one day. I slept all day. I woke up, it was about 5 p.m. And my husband said, "Did you know you've been sleeping all day?" I thought it was, when I woke up, it was morning time, but it wasn't, it was 5 p.m. And I said, "Oh my God, I feel so bad, so tired." And so, the next day I slept all day. I slept until 7 p.m. And then I actually went back to sleep, which is, I usually have trouble, with sleeping. I suffer from insomnia really bad. A couple of days after that, I got a headache. I kept telling my husband, "My head is hurting." And then like a day after that, I couldn't smell, I lost my sense of taste and smell. Very dizzy, very dizzy. When I got up out of bed, I just fell back in the bed. I was just so dizzy. My bathroom is just a couple steps from my bedroom. It was like I was like having anxiety attack to go to the bathroom, cough. I got a cough that was body shaking cough. I coughed so hard. It just seemed like my cough just pulled my whole body into it, it was just so bad. Then I stopped eating. It was just horrible. Short of breath. I was short of breath. What else? Nausea, vomiting, diarrhea. I had that. So, and then, just the muscle aches and muscle aches and everything. So it was, I thought it was pretty bad. I thought I was dying.
Did you think it was COVID-19?
I had some kind of idea that it could be because of the cough. The cough was just really bad. So, I had some idea that it could be that.
And at what point did you decide to seek medical attention?
I think I probably was about maybe 2 weeks into it. And I decided to contact Dr. Lambert and let him know what was going on. I think I told him I just felt horrible, and then he started calling me and we started conversing after that, And so he sent me to actually Lily's here, who was the only place I think that was doing testing for the COVID. It's like a drive-through, So he sent the order, and I went. I barely made it, but I went to get tested, and then it came back positive.
Can you tell us a little bit about the test for COVID-19? What was it like getting the test?
I won't say it's horrible, but it's very uncomfortable. Very uncomfortable. They take the Q-tip swab, the sterile Q-tip swab, and they go all the way basically to your pharynx, your nose and through your nose.
And how did you feel when you received the official diagnosis?
At that time, I was so sick that I just wasn't, all I wanted was relief. I just needed some relief. I wasn't shocked that that's what it was, because like I said, I had some kind of idea that that's, what it was. And so did Dr. Lambert. Yeah, at that time, like I said, I just felt so physically horrible to, all I wanted was relief from it. So, yeah.
And I understand you were hospitalized. Can you tell us why you were admitted and what that experience was like?
I was admitted, for the COVID, the cough, and the short of breath. They immediately started me on, IV fluids and medications. yeah, I was in a room, you know, you can't come out because I was a COVID patient. So, you know, you can't go out, you know, you stay in the room. So, you know, usually when I have a flare, I get to go out and, you know, walk the hallways and everything. Well, you're just in your room, very limited interaction, you know, mask on at all times. Me, myself, and the staff that came in, everyone, mask, gloves, gown, everything. No, no outside contact at all. No visitors. That was just so depressing for me because I'm so used to my family coming in and everything, you know. Yeah, I think I sat on the side of the bed and cried one night for maybe about 30, 45 minutes, you know. I was just so lonely. I was sick. And yeah, I'm kind of like a mama's girl. So my mom is always there as old as I am. So I just, you know, it was just, you're isolated, basically. You're in isolation, no contact.
This sounds like such a challenging experience. How long were you there?
I was there for 5 days.
And do you remember what types of medication you took?
What is it? Hydroxychloroquine. Yeah, I got that, and the, you know, the other medicine was just to control my cough, you know, which was the Robitussin, and IV fluids, and so those are the medicines that I got. Yeah.
Did your doctors adjust the medications you take for AIH when you had COVID-19?
Yes, they did adjust that. I was taking tacrolimus 3 milligrams twice a day, and so they adjusted that down to 1 milligram. With the prednisone, they adjusted that. I'm down to 30 now, but oh my God, I think it was 40 in the hospital. I was, you know, they were giving me 40, and that's what I was discharged with, 40 milligrams of prednisone. I was taking azathioprine also, but they told me not to take that, you know, right now. So yeah, those are the ones that they adjusted.
And after your time in the hospital, after you were discharged, what was your recovery like at home?
I'm still recovering. I am still recovering. I feel the effect. And sometimes, you know, I'm like, oh my God. But like I said, I have good days and bad days. I really feel the effects of both the COVID and the AIH, you know. It's the fatigue, you know, it's bad. I still have problems with nausea, headaches, little dizziness, you know, at times, you know. I might wake up in the morning and just physically tired, you know, which will prompt me to, you know, just be in bed all day. Some days I wake up and I can, you know, I have a little energy. But maybe an hour, 2 hours into that, I'm kaput again. So it's really a struggle for me. Fatigue is really a struggle for me. And, you know, the other symptoms are not all the time, every day, but they're there.
You know, fatigue is obviously something that many of our members experience, even those who don't have COVID-19.
Yes.
Any tips for dealing with fatigue? Anything you've found that has helped you get through the day?
Just rest. I mean, that's all you can do. The fatigue, it sometimes can be debilitating, you know, so I just say just rest. When you have some energy, when you feel like you have some energy, don't do too much, you know, just do what you can stand, because believe me, you're gonna you're going to fizzle out really fast, you know. So just really, you know, if you have energy, preserve that energy as much as you can, and you know, use it for something that you really need it for, you know. Otherwise, you know, just you try to get as much rest as possible. I always say better days ahead, and I know it's going to be better days ahead, but you know, right now in the present, you know, that's basically how I deal with the fatigue.
Any idea how you contracted COVID-19? Did you know anyone else who had it?
I have so many different scenarios. My mom was sick. She was sick maybe about two weeks, a cough, all the symptoms that I had. She had a cough, she had diarrhea, she had nausea, she had a sore throat, you know, body aches, you know. She knew that, you know, she was like, I probably have some kind of virus. Okay. I don't know if you know about nurses, but we're the hardest to get to the doctor. And, you know, I mean, we have to be like close to dying before we decide to, you know, get some medical attention. But yeah, she called her doctor and her doctor prescribed her some, you know, antibiotics. I'm not exactly sure what they were. But I went to pick up you know, her medicines for her, and, you know, and take them to her. And of course, you know, I have to hug her and everything. And later on, we found out that she had COVID also. So my mom had COVID. She took the antibiotics, she got a little better. A week after that, her symptoms came back and she got worse. She got, you know, the same symptoms, but times 10. And so she finally went to the hospital and she was diagnosed with COVID. I also have a brother that was diagnosed with COVID. So I don't know, you know, where it came from. You know, maybe it was them. My husband, he works on the road. So he came back and he had a virus. Actually, this was probably like January. I think it was January. He came and he had the symptoms that I ended up getting. And he went to the hospital. He actually went to the hospital, to the emergency room, and they told him it's just a virus. You know, go back home, drink Gatorade. You know, just kind of work it out like that. But yeah, so he got better. So I mean, he could have had, you know, COVID-19. All the symptoms were the same symptoms that I was having. So maybe, you know, it was from him. Maybe it was, you know, from my mom and my brother. I don't know. So.
You said your husband has recovered. How about your mom and brother? How are they doing?
Oh yeah, they've recovered. They're doing very well.
What will you remember most about the pandemic and your personal experience with COVID-19?
What I remember is just difficult times, very difficult. You know, the pandemic itself, just, you know, the social isolation of it, you know, being inside all the time, making you aware to wash your hands, which is something that we should be doing already, you know, but to be reminded to do that, you know, it just made me think that, you know, people really don't wash their hands as often as they should, which spreads a lot of things, you know. Washing your hands is very important. Just the difficulty of me having COVID, and trying to what's the word I'm looking for? You know, trying to deal with that basically, on top of having, you know, autoimmune hepatitis. So I, you know, at some point, you know, when I had COVID, I was trying to figure out what symptom is COVID, what symptom is AIH, you know, just kind of driving me crazy. Like, could this be COVID? You know, and, just the, like I said, the social isolation, people losing their jobs and stuff, children out of school. These are the things, that I would definitely remember from this era and, this time from the COVID and from the pandemic and everything. And just the sheer, people being just scared, and especially immunocompromised patients, just being just scared and, not wanting to get it. And, oh my God, this is just horrific for some people, for some people it's not, but, for me, very scary times.
As we wrap up, any advice for fellow AIH patients during this pandemic, or anything else you'd like to add or say?
My fellow AIH patients, stay inside. If you have to go outside, put your mask on. Stay your distance, from people. Don't let people, come over, keep your house like, a sanctuary, talk to them at the door. And I know that's difficult. It's definitely, especially for family and everything, but, your health is very important. So, just be leery of everyone coming over. Like I said, talk to them at the door, wash your hands, wipe down your appliances, your kitchen, all your surfaces and everything. Just keep doing that. But, most important thing, don't go out if you don't have to.
Thank you so much for participating in our webinar and being here today. We wish you the best in your continued recovery. And we also want to thank you for your service as a nurse. It's National Nurses Week, and we're sending our thanks and good thoughts to all essential workers, especially those who are AIH patients. Thank you again.
Thank you. Thank you. And it was my pleasure.
Thank you. We'll turn it back over to Dr. Lambert now.
Thank you, Aricia and Aaron. And thank you for joining us today. And special thanks again to Aricia McCrae, who provided a glimpse into the patient perspective of AIH and the coronavirus. Thank you again to the collaborators of the AIHA, specifically Dr. Aaron Ermel, the Center for Autoimmune Liver Disease, and Cincinnati Children's Hospital. We hope you'll join us again in 2 weeks for our next webinar.